Hi, good morning, everyone. My name is Eric Layland, and I'm a new assistant professor in human development and sciences at the University of Delaware. And my research centers the health and developmental experiences of LGBTQ people and communities. And today I'm going to talk about quantitative methodological innovations that allow us to use secondary data analysis to better model health disparities across the lifespan, differences in health within the LGBTQ community, and the influence of laws and policies on individual LGBTQ developmental and health outcomes. And so I want to set the stage first by introducing a key theory and innovating in methods around how we understand health based on this theory. So minority stress theory was developed by Jenny Brooks and expanded by Elon Meyer. And they proposed that minority stress is specific psychological distress due to stigma that devalues sexual and gender minorities for violating norms of heterosexuality and cisgender normativity. And this minority stress is unique to LGBTQ folks, and it is persistent and chronic and takes on many different forms. And minority stress couples with general life stressors to explain disparities in mental and behavioral health between LGBTQ folks and cisgender or heterosexual people. And although this theory is very popular in the research, there are some limitations to how the theory is applied. And I'm going to highlight three limitations and how I've innovated with methods to address those limitations. So first, the effects of minority stress are presumed to be stable and the same across the life course. And the second, most researchers assume experiences and effects of minority stress are homogeneous across the LGBTQ population. And then finally, a focus in minority stress tends to be on interpersonal, so social and person-to-person experiences of everyday discrimination. And so these three assumptions are big limiters to what we're able to understand in LGBT health. So in the first example, I'm going to demonstrate how time-varying effect modeling allows us to use cross-sectional data to estimate changes in health disparities across the lifespan. And this approach makes a major contribution to LGBT health research by considering differences in suicidality at the intersections of age, race, and sexual orientation, while also integrating minority stress as an explanatory factor of those life course differences in suicide attempts. Okay, so time-varying effect models are an innovative approach that allows us to estimate effects that are allowed to vary or change at every point in time in the data. And in cross-sectional data that spans across many ages, we can use the data from each individual to approximate age-varying effects or prevalences across the life course. And thus we can identify disparities between groups and identify the time periods in life when these disparities are greatest. So in the study that I led, we used time-varying effect models and study of adults ages 5 to look for changes in disparities in suicide attempts between heterosexual and sexual minority adults stratified by race. So I'm going to quickly walk through these results. For ease of interpretation, I've split a few figures out stratified by race, so that technically all of these different groups are comparable to each other, and the results are fairly stable across racial ethnic groups. So in this figure, the black line represents the age-varying prevalence of past 5 years suicide attempt for Hispanic sexual minorities, and the gray line is the prevalence for Hispanic heterosexuals. And we see that across the life course, this disparity is greatest at age 18 and declines until about here at age 35, where the lines converge and there's no longer a significant difference between heterosexual and sexual minority adults. If we then look at Black adults, we see somewhat similar disparities, where the gap closes again in the mid-30s, representing the age period when we no longer see a disparity between heterosexual and sexual minority adults among the Black subsample. And then finally, for white adults, the disparity is again greatest in early adulthood, but persists longer than for Black or heterosexual adults into about the mid-40s. But additional analyses revealed that for every age group, stigma or minority stress only predicted the disparity here. suggesting that in early adulthood, the impact of stigma on suicide disparities is unique in this age period, and a need for intervention in this period that addresses stigma. So then another question challenging the assumptions of minority stress theory is to understand how subgroups of the LGBTQ community experience stigma differently. And latent class analysis is an approach that we can use to understand how subgroups may experience different patterns of racist and heterosexist stigma, and then how these subgroups may differ in their health outcomes and other correlates of stigma. So we identified 5 subgroups, and there's a lot to talk about these subgroups, but in this cohort example from Children's Hospital Los Angeles, with gay and bisexual men of color, we're going to focus today just on the compound stigma class, which was the group that experienced the most ubiquitous and pervasive and severe and frequent forms of both racist and heterosexist stigma. But this subgroup stood apart in the severity and intersecting nature of the stigma they experienced. Then when we take these subgroups and look at the compound stigma subgroup compared to the others across these many different measures of material and health needs, we see with those orange bars across unemployment, sex work, unmet basic needs, food insecurity, and unstable housing, the compound stigma group, who also had the most severe experiences of stigma, was different than the rest of the sample in their access and achievement of basic needs. When we take that into a health space, then we also see that that group was uniquely elevated in their prevalence of sleep disorders, gastrointestinal disorders, and unmet mental health needs, highlighting that the experience of stigma varies and that those different patterns in stigma can reveal subsets of the population who are especially at risk in exhibiting these elevated unmet needs and health problems. And then in the next study, what I'm going to show is more about how country-level structural policies can impact individual outcomes. So a lot of times we focus just on the experiences of stigma and discrimination person to person without thinking about how the broader context can impact individual development and health. This is especially important in a time when a lot of laws are changing. There's over 400 anti-LGBTQ laws that have been proposed so far this year in the US. So this allows us to nest individuals within countries in this example to see how structural policies can be either supportive or antagonistic of individual sexual minority outcomes. So to set the stage of what outcomes I looked at specifically, because of my training and interest, I do not only health research, but also developmental research. And for LGBTQ young people, this can include unique developmental tasks of understanding and integrating their own identities, very focus on the disclosure of their sexual minority identity to others. And scholars have posited that the closet is a unique period of isolation between when an individual knows of their own identity and the first time they share it with another. And this unique period of isolation can be a time that restricts access to affirmative health care, social resources, the opportunity to explore and integrate identity. And so we looked at how these systems of structural support, so that is protective policies at the country level, were associated with these individual level outcomes, which is a uniting of policy work and developmental work that has never been done before. And we used this unique data set in Europe that had the largest study of LGBTQ folks with more than 110,000 lesbian, gay, and bisexual adolescents and adults. So using multi-level models with cross-level interactions, we tested how that policy impacted these milestones. And what we see is that in countries with the most supportive policy, young people were coming out and disclosing that identity earlier, and by extension, spending a shorter amount of time in total isolation in the closet, thus demonstrating how these federal and state structural level policies can facilitate the development and by extension, the healthy development of LGBTQ young people. And so in summary, across these 3 examples, I'm offering some innovations and understanding how We can use methods in secondary data analysis to push the field of LGBTQ health in new directions, to understand the ways that disparities vary across the life course, that subgroups experience stigma and health differently, and that multi-level models that incorporate structural and country or state level policies can inform that impact on individual level outcomes. And currently, I'm working with colleagues at UD and abroad to better understand the strengths and positive processes for LGBTQ folks, how this impacts health and development, especially in a family setting, how experiences of minority stress and queer joy can come together to be reflected differently at the physiological level to understand the protective and risk factors across levels experienced by LGBTQ folks. And these innovations are especially critical given the ongoing everyday political pushback and backlash denying queer and trans folks basic rights and access to affirming resources in healthcare. And so with that, I thank you for your time and this opportunity to share more about the health and development of LGBTQ young people.
I left a little gap there. So Suzanne, just stop the recording. There'll be a recording stop, but we can truncate off the end part.